that we normally don't see or normally don't even think about. So thank you so much. We thank you that you've been part of our team today. Now I'm going to show you two things. One is we have Dr. Sheba here, who is a leading pathologist in the city, and she would show you things that you normally don't see. And I will, at the end of her talk, I will also show you certain things which you normally don't see on table. Things to do with the base of heart. So we would show you a deatrialized specimen of the heart and the interrelationships of the valve. So that would follow the talk on things that you normally don't see, normally that you need a microscope to see. So over to Dr. Sheba, pathologist.
Good afternoon, everyone. Now we are going to zoom inside the heart and see the cells magnified from 100 to 1,000,000 times. So first we are going to see the pericardium. So this is the horizontal cut section. You can see the visceral pericardium and the parietal pericardium and the space in between. The pericardium envelopes the heart. It's a fibrous structure lined by mesothelial cells and can have adipose tissue. The parietal pericardium is reflected off the ascending aorta, the pulmonary trunk, the terminal 2 to 4 centimeter of the superior vena cava, and the distal segment of the inferior vena cava and the pulmonary veins. It is inelastic and up to 50 ml of fluid can be present. But if there is more fluid accumulation and it is acutely stretched, it causes cardiac tamponade. Heterotopic tissues like thyroid and thymic elements can be present, and it should not be mistaken for metastasis. So this is a descriptive picture. So you can see the multiple layers of the heart. You can so this is the parietal pericardial layer lined by mesothelial cells, and there is a fibrous tissue, and this is the visceral pericardial layer over the myocardial cells, and this is the inner surface. So this is a light microscopic view. So of the pericardium, it is lined by mesothelial cells on the surface. This is a fibrous tissue and this is the adipose tissue. So this is a visceral pericardium, the layer of mesothelial cells beneath which there is adipocytes with nerve bundles and blood vessels. So this is a scanning electron microscopic view of the pericardium. So you can see the surface lining by mesothelial cells, and there are adipocytes in between, and these are the reticular supporting fibers. And here you can see the cross section of a coronary artery, and you can even see the inner elastic lamina very clearly. And so this is the endothelial lining of the coronary artery. So this is almost 1,000,000 times magnification of the adipocytes, and you can see in the insert you can see the coronary vein. So this is part of the blood vessel. You can see the lining endothelium. This is the cut surface of the myocardium, and this is the endocardium and the supporting reticular framework in between the myocardium and the endocardium. Coming to the myocardium. Myocardium consists of predominantly of cardiac muscle cells, which are 120 microns long and 20 to 30 microns in diameter in a normal adult. Each cell has one or two large nuclei occupying the central part of the cell. The cells are branched at the ends, and the branches of the adjacent cells are so tightly associated that their appearance under light microscopy is of a network of branching and anastomosing fibers. Cells are bound together by elaborate junctional complexes, the intercalated discs. So this is the view of the cardiac muscle cells, intercalated discs here, and these are the striations, these are the nuclei. And this is an electron microscopic picture of the cardiac muscle cell. You can see the large nuclei, and close to the nuclei, the myofibrils separate, and so there are some spaces in between here, so where the organelles are present, and the heart is rich in mitochondria. As you age, the increase in lipofuscin granules. These are reddish brown pigments. So this is a scanning electron microscopic view of the myocardial cells. You can see the branching fibers, and this is a longitudinal view of the fibers, and this is a cross-sectional view of the muscle fibers. So there is fine fibrocollagenous tissue between the cardiac muscle fibers, and capillaries and some nerve bundles are found within them. And coarser connective tissue fibers are there, separating larger bundles of muscle fibers, and is particularly well developed near the condensations of dense fibrous connective tissue that form the skeleton of the heart. So the ventricles of the heart are composed of spiraling layers of fibers that run in different directions. Consequently, in microscope sections, they contain profiles of cells of different orientations. Linear arrangement of cells are only found in the papillary muscles. So this is a papillary muscle, and you can see this is lined by the endocardium, and this is a section of the papillary muscle where there is linear orientation. So there are some mild differences in the arrangement of cardiac muscle in the atria and the ventricles, or the layers are present, but the myocytes are loosely arranged and some fat can be present. In the ventricles, it is more compactly arranged. Coming to age-related variations, brown atrophy, there is lipofuscin pigment increases with age, and also the proportion of the cytoplasm, it is more, in the infant, it is much less compared to the adults. Also, there is some perivascular collagen around the blood vessels, and the papillary muscle fibers can have some fibrosis near the chordae tendineae. So you can see this pale pink material is a fibrous structure. It is not pathological fibrosis. And this is Masson's trichrome staining towards the annulus. So near the valves also there can be some fibrosis. And around the blood vessels, mild fibrosis can be present. It's not pathological. Pathological fibrosis will look like this. See, the muscle fibers are here, dark pink stained, and pale pink stained is the fibrosis, and it can be highlighted by Masson's trichrome. So this destroys the muscle fibers and there is fibrosis in between. The heart has significant degree of plasticity. Physiological and pathophysiological stimuli can initiate cardiac remodeling. And pathological hypertrophy, there is cardiac damage. Myocyte disarray can be found within the trabecular muscles and should not be confused with hypertrophic cardiomyopathy. Few endogenous progenitor cells capable of regenerating are present, but they are unable to restore the heart function after ischemic or other injury. Slow continuous renewal of cardiac muscle cells are present throughout life, around 1%. So coming to the cardiac skeleton, it's at the base of the heart. It's a central supporting structure where the AV and the aortic valves are anchored. The conus ligament joins the pulmonary ring to the aortic ring. It separates the atrial and the ventricular chambers. And it is mainly made up of dense collagenous, the fibroskeleton is made up of dense collagenous connective tissue. some elastic fibers and adipose tissue. So coming to the valves of the heart. So the valves, they provide the tensile strength and pliability for decades of repetitive motion. So they have this zona fibrosa, that is fibroblast and collagen fibers, ventricularis with elastin-rich fibers, and spongiosa, which is of loose connective tissue. So this is the orientation of the fibrosa and the ventricular and the elastic fibers. So coming to zona fibrosa, it's a dense collagenous layer in continuity with the annulus, bounded on either side by elastic fibers more prominent beneath the endothelium. The elastic fibers diminish throughout towards the free edge of the leaflets. Spongiosa is a central layer composed of loose connective tissue, fibroblasts, and interstitial cells. It's more prominent near the annulus. And in the semilunar valves, atrial myocardium, nerve bundles, and lymphatics may infiltrate the spongiosa near the annulus. Ventricularis, it has elastic fiber. There are multiple layers of elastic tissue. It lines the ventricular surfaces of both the semilunar and the AV valves and also coats the tendinous cords. So this is a tendinous cord. You can see a central muscle coat and surrounded by fibrous tissue and elastic tissue. And this is the electron microscopic view of the same. Age-related variations, diffuse rubbery thickening can happen, and there is accentuation of the noduli arenti, mitral annular and sinotubular junction calcification. Mostly this calcification and fibrosis occurs in the fibrosa, and sclerosis and expansion of loose connective tissue in the spongiosa can also occur. This is the view of the endocardium supportive connective tissue in the beneath the endocardium, and these are the cardiac muscle cells. Coming to the conduction system of the heart, we look at the sinoatrial node, SA node. It's a specialized pacemaker myocyte collection located in the right atrium. It is a subepicardial structure near the superior vena cava. It consists of nodal cells, transitional cells, and atrial muscle cells. It's supplied by the sinus nodal artery. So you can see the artery here, and this is surrounded by the SA nodal cells. So nodal cells, it's very difficult to appreciate. It's surrounded by fibroblasts. So nodal cells are small, oval, and pale staining and poorly striated compared with the general myocardial cells. They are grouped together and separated by fibrous tissue. They are thought to be the source of normal impulse formation. In infant, nodal cells predominate compared to the fibrous tissue. And after that, there are some transitional cells. They have characteristics intermediate between the packed nodal cells and individual atrial myocardial cells. And transitional cells are located at the margin of the node, where the nodal cells become contiguous with the atrial myocardium. So this is the light microscopic view. These are the pale nodal cells in between, and these are surrounded by lots of fibrous tissue. And this is a nerve bundle, and here they merge with the atrial myocardium. So this is the scanning electron microscopic view of a nodal cell. And this is an electron microscopic view of a nodal cell, which is P cell, pale cell. These are the cells here, and these are surrounded by fibrous tissue. And this is a transitional cell, and this is a capillary. So this is another electron microscopic picture showing the pale cell. This is a cross section, and this is a transitional cell, and this is a capillary with the erythrocytes. Coming to the AV node, it's a specialized conducting myocytes within tricuspid annulus near the AV septum. It's a subendocardial structure. You all know Koch's triangle, and supplied by the AV nodal artery. So you can see the triangle of Koch. So from here we are going to take sections through this and going to see the microscopic view of the AV node. So these are the sections taken from that region. And so you can see here these AV nodal myocytes, transitional cells, and these are the HL myocytes. This is the AV nodal artery. So this is a section taken from that area. So you can see this is the inter-atrial septum. It's a part of the mitral valve. This is a part of tricuspid valve. And you can see the nodal artery. You recognize that first, and then you see surrounding tissue is the AV node. So this is the hyper view. So this is the artery. This is the Movat's pentachrome stain. And so these are the AV nodal cells surrounding it. This is another section. This is Masson's trichrome. So you can see the valve and the valve annulus, and this is AV nodal structure here. And in another section, there is bundle of His, and there is a right bundle branch in this section. This is another section showing this is a myocardial cell, and this is a left bundle branch and some smooth muscle bundles above that. This is an electron microscopic view of an AV nodal cell. This is a SA nodal cell, and this is the AV node cell. So these are branching cells, and you can see the nuclei is in the center. These are all modified myocytes. This is another electron microscopic view. This is a Purkinje cell closely approximated with the transitional cell. You can see the intercalated discs here. These are the organelles, and these are the striations. This is a scanning electron microscopic view of a Purkinje cell approximated to the cardiac muscle cell. See the branching structure, it is just on the muscle cell. This is another colored scanning electron microscopic view. See the green one is a Purkinje cell, and it is branching and closely approximated to the muscle cell, which is cardiac muscle, which is red. So last but not least, when we look at the right atrium, in around 2 to 3% of the individuals, we might see this Chiari network. This is nothing but a remnant of the sinus venosus. It is closely approximated to the inferior vena cava. It can be a lace-like structure, or it can be a membranous type with a sieve-like appearance. Importance is it can be present in people with patent foramen ovale, and in other scenarios, they say if it is present, it can obstruct thrombi or emboli entering the heart. But apart from that, this can itself be a nidus because it causes turbulence and forms thrombi, and it can have embolic showers. And during catheterization, it can cause hindrance for catheterization. So it cannot be found during usual echograms. So you need a transesophageal echo to find this. So you should keep this in mind, this unusual structure that can be present in 2 to 3% of the individuals. Microscopically, just a fibrous tissue, just fibrous connective tissue, no myocytes are present. These are my references. Thank you.
Thank you, Dr. Sheba. In fact, you told us how electricity goes through the Purkinje cells right to flogging the worker myocytes. Fabulous, fabulous. That's a very good insight given to us by the pathologist. As I promised you, I thought I'll show you some few specimens to finish up. We would now show you the base of the heart, which has been dissected for you. Come on. Okay, so this is a deatrialized specimen. Okay, so this is the mitral valve, and you could see the AML, PML. The PML is the mural leaflet, the AML is the septal leaflet. Okay. So here, this is the tricuspid valve. Okay, focus. Yeah. So the tricuspid valve, you could see the septal leaflet here. Somebody has to show the light. Okay, so that's the septal leaflet there. And this would be the large anterior leaflet, and that's the posterior leaflet. So that's how the surgeon would probably see it. So the septal leaflet would be towards him. The posterior leaflet behind, the anterior leaflet in front. Okay. Okay. So between these two, you have the interatrial septum. And where this hits the aortic valve, that is your non-coronary sinus and the non-coronary cusp. Okay. So this is a feature in the echocardiogram as well. Interatrial septum onto non-coronary cusp. Okay. The right is there, giving off the right coronary artery, which goes around the tricuspid valve. And the left is here, left main. Okay. That gives off the circ, which goes around the mitral valve. The coronary sinus also goes around the mitral valve. So when you see a mitral valve like this, as in the surgeon's position, the aorta is there, AML, PML, and your circumflex around, your coronary sinus around. Okay. And this is the pulmonary artery, pulmonary valve. If you see that all these three fellows are sitting at one level and this guy is sitting a little bit higher, that is because of the presence of this conus. So this conus pushes the pulmonary valve above. And the pulmonary valve has one anterior leaflet and one right and left. And the aorta has the posterior leaflet or the non-coronary leaflet and the right and left. So the aorta will have a posterior leaflet and the pulmonary artery will have an anterior leaflet. Okay. I would trans-illuminate the aortic leaflet for you a bit. So you could see the nodule of Aranciae, which is nicely seen in the specimen that we found. So if you have a look at this, if you have a look at this, so that, it's probably too bright. Okay, so the nodule of Aranciae is here, and this is one lunule, this is another lunule. So you have 2 lunules for each leaflet, so 6 lunules for each valve, 12 lunules for the heart. So this is the clear portion. This is the rough portion where it coapts with the corresponding lunule of the neighbor and the nodule of Aranciae. And when we pop this into the right, as Dr. Vijit showed you, you could see the membranous septum here. These are the interleaflet triangles on both sides. So this is your non-coronary cusp with nothing here. That's your left, and and this side is your right. So your central fibrous body will be here, and your left fibrous trigone would be there. And if you would see that in this detailized specimen, that would be the area of the central fibrous body, and there would be your left fibrous trigone, and this is your aortomitral curtain, which hangs between the two. So that is your mitral valve. So that's your aortomitral curtain, and that is NCC, LCC, aortomitral curtain, NCC, LCC. These are the areas where a lot of aortic root widening gets done, and then the incision will probably go into the AML as well. So this is the area of aortic root widenings. Okay. Now, to show you a little bit of what Dr. Suresh had been explaining, this is the vertical layer where the muscle fibers are going vertically. This is the outer layer in the LV. The inner layer is the circular layer. So there was a guy called Torrent Guasp who had dissected the heart out into a helix. And the result of what he would show us is this. So the entire heart muscle is one big rope which is wound around like this helix. The inner circular fibers of the left ventricle, and this is the vertical fibers of the left ventricle which go like this. So the heart with its architecture for you as per Torrent Guasp. So I think we've had a reasonable 4 hours trying to understand the nuances of cardiac anatomy. We have had a lot of speakers with a lot of experience who put in a lot of effort into showing you the things about the heart. So we have discussed basic anatomy and how they affect diagnosis, symptoms, treatment, surgery, and I think that has been a good 4 hours for us. Normally this would go on for 2.5 days and we have a lot of applied things to show you, but this year we thought this would be short and sweet and we would do it this way. We planned one for next year in July, around 25th. We would get the information out and there we would see that if the corona goes away and we could get people into the auditorium, we would probably have a more hands-on and interactive session. So until then, it's goodbye from all of us. Come along, guys. I let my... Come. So these all...
Jaswin should also come.
Yeah, come, just come. Jaswin, come, Jaswin.
Come, Sanjay.
Come, Sheba, come. Come. From all of us here at the Madras Medical Mission, our cardiac morphology team, and a lot of friends from outside as well who've been part of this team for so many years. I think cheers, and hopefully 2021 we will join together in an auditorium and have a session of interactive, hands-on cardiac morphology like how it's always been.
Thank you.
Thank you.